All right, good morning, everyone, if it's morning where you are, and welcome to the 56th seminar in the Centre of Research Excellence in Aphasia Recovery and Rehabilitation Seminar Series. I'm Dr. John Pearce, postdoctoral researcher at the Aphasia CRE, and I co-host these seminars alongside Dr. Rebecca Sullivan, who is also our speaker today. I'd like to begin by acknowledging the traditional owners of the lands across Australia, and I pay my respects to elders past, present, and emerging. I'm speaking to you today from the lands of the Boonwurrung people of the Kulin Nation, and I extend that respect to any Aboriginal and Torres Strait Islander people with us today. So for a change today, Rebecca Sullivan is going to be presenting rather than hosting, and she's going to be presenting on communication disability plays a massive role, improving management of hospital falls in patients with communication disability after stroke. Before we get underway, just a quick reminder about how to interact during these seminars. Please submit any questions using that Q&A function in your Zoom toolbar. You can send them through at any point during the talk, and you can also upvote questions that you'd like to see answered. And there will be some time at the end to address as many of these as possible. So it's now my pleasure to introduce Dr. Sullivan. Rebecca is a Wiradjuri descendant and certified practicing speech pathologist. She graduated from the University of Sydney in 2006 and has extensive clinical experience working with adults experiencing communication and swallowing difficulties in hospital and community settings. Rebecca completed her PhD through the University of Technology, Sydney, which examined the falls of hospital patients with communication disability following stroke, using a mixed method designed to explore the impact of communication disability on falls management in rehabilitation. Rebecca's PhD was motivated by the lack of recognition of communication difficulties in patients who were experiencing falls in inpatient rehabilitation. After completing a cohort study, which was presented at a Speech Pathology Australia conference, she was recruited to a PhD via Twitter, of all things. Currently, Rebecca is an early career researcher focusing on improving the care and safety of hospital patients with communication disability. Welcome, Rebecca, to the other side of the microphone today.
Thank you. Thank you. All right. How's that?
That's great. Take it away.
Excellent. Thank you. So today I'm going to be presenting my PhD research, which examined the role of communication disability following stroke in the hospital falls of patients with stroke. So this research was funded by an Australian Government Research Training Program scholarship and a Jambana Institute postgraduate research scholarship. And I'd like to thank everyone that took the time to reschedule today after apologising. I was very unwell for our last session. So communication disability affects approximately 64% of people with stroke, and patients with communication difficulties are 3 times more likely to experience a patient safety event during their hospital admission. Falls are one of the most common patient safety incidents to occur after a stroke and can lead to poorer outcomes for both patients and health services. The risk factors for falls are multifactorial, and they include muscle weakness, difficulties with visual and spatial awareness, and difficulties with balance. In the 2024 Australian Stroke Foundation Rehabilitation Audit, 18% of patients experienced a fall during their inpatient rehabilitation, which was the most prevalent complication reported. So there is good reason to focus on the role of communication disability in falls. Successful communication between patients and health professionals is essential to providing safe healthcare, and communication disability can lead to a breakdown in that communication. It can inhibit a patient's ability to communicate their healthcare needs, call for help, use the call bell, or follow safety instructions like don't walk alone or use the buzzer if you need the toilet. And these are the things that might lead to falls. So my PhD focused on examining the role of communication disability in the falls of hospital patients with stroke through literature reviews, analysis of medical records, and clinician focus groups. So from this work, I was able to present some guidance for health professionals to manage falls in these vulnerable patients. So the plan for this session is to present the results of the 6 studies of my PhD integrated into a patient journey. So I'm going to present the methods of each of the studies first, and then talk about the results from them in a group in relation to the patient journey. So for example, when I'm talking about risk factors, I'll discuss what the literature reviews found, what I found in the medical record and incident reports, and then what the focus group discussed. So I'll do that for each step of the patient journey, and then finish by bringing it all together into some clinical recommendations. All of the studies are published, and if you scan the QR code at the bottom of each slide, it will take you to the links. The majority of these are published open access. So each of the studies in my PhD informed the next one, building a continuous line of inquiry. It started with a systematic review, which aimed to determine if communication disability is a risk factor for a fall. Then a qualitative metasynthesis of that same literature examined what was already known about where, when, and how patients with communication disability fall. Next, I did a scoping review of hospital falls policies across Australia to understand how communication appears in those policies. And then I examined the medical records and incident reports from a health service. So I did that firstly to understand where and when and how patients were falling, and then to understand how communication disability appears in relation to those falls. Finally, I conducted focus groups with health professionals, hospital staff, to explore their views on the effect of communication on falls and prevention strategies and any potential role for speech pathologists. So whilst each study had its own method, the generic reference model of patient safety provided a theoretical lens for the studies. So this is a framework that can be used to guide the collection and analysis of data in relation to patient safety incidents. You can see that the model organises the elements of an incident into three key areas: the contributing factors and hazards to the incident, the details of the incident, and the outcomes and consequences. So across the studies, this was the model that provided the framework for the data collection and analysis. So the systematic review included 15 studies. I analysed the data using a meta-analysis and narrative synthesis. The qualitative studies included the qualitative synthesis included those same 15 studies, which were examined according to the generic reference model of patient safety to map what was already known about falls in this population. I then did the review of policies, which included 50 documents that were available on public health service websites and analysed using a content analysis. For the medical record review, all stroke admissions to 2 subacute rehabilitation wards over an 8-year period were screened for inclusion. Participants were included if they had a left hemisphere stroke confirmed by CT or MRI, a new communication disability diagnosed by a speech pathologist, which is important, and a fall or a near-miss fall during their inpatient rehabilitation. So for these studies, there were 109 participants, and these 109 participants experienced 308 falls. 58% of the participants were male, the average age was 75.5 years, and the average length of stay in inpatient rehabilitation was 47 days. The documented communication disabilities included aphasia, dysarthria, apraxia of speech, and cognitive communication disability, or a combination of those. So you can see from this slide that the majority of participants had a severe or profound communication disability and had significant functional impairments on admission in relation to their mobility, continence, and ability to complete self-care tasks. So after the document data, I conducted online focus groups. Recruitment for these groups was conducted through social media and professional networks. Health professionals from medical, nursing, and allied health were invited to participate if they'd provided clinical services to hospital patients with stroke and communication disability who had experienced a fall or a near-miss fall in Victoria, Australia. The topic guide for the focus groups was informed by the findings of the previous studies. Each focus group was presented with a 5-minute summary of the findings to ensure that they all had a similar background knowledge. There were 11 participants, 6 nurses, 3 speech pathologists, 2 medical doctors, with an average of 7.4 years working with people with stroke. So now I'm going to present the results of the 6 studies in groups rather than separate. So I'll start by discussing the risk factors for a fall, so what we found in the literature, the medical record review, and what the focus group says. So I'll do the same for the fall itself, the contributing factors to a fall, and then what happens after a fall. So down the side of the slide through the presentation, you'll see this flow chart, and that'll be the indicator of what part of the patient journey I am discussing. So starting with identifying the risk factors for a fall. This is something that usually occurs at the beginning of a patient's journey when they are admitted. In the literature, the meta-analysis showed no statistically significant association between patients with communication disability secondary to stroke and the risk of falls in hospital. However, the rate of inclusion of patients with communication disability in this falls literature was low, and there was a potential selection bias through exclusion criteria towards patients who had a mild or moderate communication disability. So we're talking about a number of papers and studies excluded patients with severe communication disability. There were variable definitions of communication disability, and only 3 of the 15 studies used a speech pathologist to actually diagnose communication disability. However, in 2 of the 15 studies, a significant association between communication disability and a higher rate of falls was found. And these 2 studies both had patients with severe communication disability in their populations. In the falls policies, across the risk assessment and screening tools included in the review, there was a strong focus on screening and identifying well-known falls risk factors. When looking at communication, difficulties following instructions appeared in 2 of the 9 screening assessment tools, and there were some aspects of communication difficulties that were conflated with cognitive impairments, which we know is problematic. So while some cognitive impairments impact on a person's communication, communication and cognition can be mutually exclusive in that it's possible to have a communication impairment with intact cognition. So looking at the identification of communication disability as a risk factor for a fall in the medical records. In 10 patients, so 9%, communication disability was documented as a risk factor for a fall. This was specifically in relation to the patient having difficulties following instructions, and it was often documented in conjunction with a physical impairment. So this is demonstrated by the quote, "Patient has significantly decreased sitting balance and is inconsistent following commands, significant falls risk." The nursing staff also noted other aspects of impaired receptive language or comprehension that could potentially impact on falls. In their documentation, nurses often described participants as being disorganized, having difficulties responding to redirection, or having difficulties following safety instructions, as in this quote, "transfers very poorly, does not respond to one-step commands." Focus group clinicians supported the idea that communication disability was a potential risk factor for a fall. One participant stated, "They're having trouble communicating that they need help, so they're more likely to just go and do something themselves." Participants across the groups acknowledged that a patient's communication disability is not often considered, even though it might be a factor. They discussed considering a patient's cognitive impairment and physical function more than communication disability. One participant stated, "We talk more about the cognitive impairment and don't look too much into the communication disability." So unfortunately for a number of patients, the next part of their hospital journey through rehabilitation may actually include a fall. And so this is where we'll focus now. There were no studies in the literature that specifically provided details on falls for patients with communication disability. So in the literature review, we focused then on patients with stroke. So patients commonly experienced a fall in their bedroom, during the day, and during transfers. There was not a lot of detail about whether these falls were witnessed or unwitnessed. And the studies reported that family members or visitors provided a protection against falls. However, that was not consistent because in 2 of the studies, they reported that inappropriate assistance by family or visitors actually contributed to a fall. In the medical record review, we sought to understand this gap and understand where and when and how patients with communication disability experience falls. So as I mentioned, the 109 participants had 308 falls, including 18 near-miss falls. The majority of patients experienced a fall in their bedroom and were found on the floor by staff. More than half of the falls were unwitnessed, and falls occurred at all times of the day and night. Really importantly, 47% of patients with communication disability fell more than once during their hospital admission. So almost half of the falls were a roll from bed, and this was followed by a fall during transferring, a fall from a standard height bed or chair, or during mobilisation. Of the 135 rolls from bed, 117 of these were from only 17 participants. So from the medical records, we identified that there were 4 common circumstances of fall. So these are the things that the patients were trying to do when they fell. And these circumstances were attempting to address an unmet need, taking a risk, difficulties following instructions, and where the circumstances of the fall were unknown. So the unmet needs were mostly related to toileting. Patients were described as being found on the floor, needing personal hygiene care, and this is described in the quote, rolled off the bed after being fecally incontinent. Staff also reported patients being found attempting to make their own way to the toilet, scooting on the floor or falling whilst attempting to mobilise to the toilet. So there were 27 patients who experienced 47 falls attempting to meet a need. So where falls occurred when the patient was taking a risk, the majority of these were during a transfer. The documentation of these falls reflected that staff thought these were the responsibility of the patient. Patients were described as trying to mobilise on their own or not calling for assistance, and this is reflected in the quote, unsafe, unsupervised transfer from the bed to the chair. There were 35 patients who experienced 50 falls whilst they were taking a risk. There were 5 falls where a participant had difficulties following instructions. The instruction was related to preventing a fall. So, for example, trying to stop a patient from leaning too far forward in their wheelchair, or during a task which was demonstrated by patient had an unwitnessed fall whilst transferring from chair to bed, patient not following a transfer instruction. There were 31 participants who experienced 97 falls where the circumstances were unknown, and this was due to the severity of their communication disability. These patients were described as being poor or vague historians and were unable to report on what they were attempting to do before falling. Most often, these patients were found on the floor by staff during their usual rounding. The falls that occurred with unknown circumstances were discussed by the focus groups, particularly the nurses. They described trying to figure out what had happened by investigating the environment where the patient was found, how the patient was positioned when they were found, and their knowledge of the patient's routine to try and help piece together the circumstances of the fall. One participant described this as, it's an unwitnessed fall, we're speculating. But at the same time, I'm assessing the other risk factors as well. I'm looking at all of those intrinsic factors. I'm looking external, what was the environment around them? Another participant described, this is a really tough one because the nurse is not there and I'm trying to take a guess of what really happened. So one of the steps after a fall is trying to determine what are the factors that contributed to a patient having a fall. And this helps staff put in place more specific falls prevention strategies. In the literature, the contributing factors and hazards for falls were reported to varying degrees and with great diversity. Although all studies reported on the person's intrinsic risk factors for a fall, like a balance impairment, there was little commonality in those factors that contributed. There were no studies that reported on this specifically for patients with communication disability. So in looking at the contributing factors to falls in the medical records and incident reports, half of the 309 falls were attributed to a patient factor, such as agitation or balance impairments. In nearly 1/3 of the falls, a contributing factor could not be identified. And again, this occurred when the fall was unwitnessed and the patient had a severe communication disability and was unable to describe what happened. Participants who fell for an unknown reason often experienced multiple falls where a reason was unable to be identified. In the records, we identified that the patient's ability to gain the attention of staff for assistance, their ability to communicate their basic needs, and the ability to follow instructions contributed to falls. So it was mostly the nurses that documented how a patient got attention, and it was usually when they were writing about a functional task, like pushing a call bell to go to the toilet. Methods for gaining attention were things like using the call bell, calling or shouting out, or becoming restless, which activated the bed chair alarm. And that's demonstrated in the quote, "Patient initiates toileting by fidgeting." Nurses also documented when patients were unable to get attention, and they used things like unable to initiate care needs, as described in the quote, "Difficult to communicate with the patient, does not initiate care needs." There were 11 patients who were documented as being unable to gain attention, and these 11 patients experienced 65 falls. The ability to communicate basic needs includes being able to say that you need the toilet, you're hungry, you're in pain, or you're hot or cold. There were 21 of the 109 patients described as being unable to communicate their basic needs due to a severe communication disability. In the notes, these patients were described as being vague or unable to communicate effectively or non-verbal. So the quote here is patient unable to verbalize their needs. The 21 patients who were unable to communicate their basic needs had 147 falls. Across the focus groups, participants viewed a patient's communication disability as a contributing factor to a fall. One participant said, "I definitely think it plays a massive role." Participants expanded on this using specific examples, such as they're trying to reach for it, but unable to use their words to communicate and tell people what it is that they want. And with communication difficulties, it's hard to get that message across to the patients that you need to use the call bell if they don't know how to use the call bell. Participants also viewed that the time it takes to communicate with a patient with communication disability may also contribute to a fall. One participant explained, when someone does have a communication disability, it takes so much longer to work out what they need. And hospital wards are really busy environments, and staff often feel like they don't have the time to spend. So moving now to what happens after a fall. In the literature, the severity and type of physical injury was reported in 13 of the 15 studies. The majority of participants in the literature sustained either no injury or a mild injury from falling. The range of severe injury, such as a fracture, was 0.6 to 5.6%. There were 3 out of the 15 studies that reported a statistically significant difference in the length of stay of patients with stroke who fell in comparison to patients who did not fall, but this wasn't a consistent finding. So in my studies after a fall, there was limited information or insight into the outcomes for either the patient or the hospital. In terms of injuries, there were 49 injuries, and they included 1 fracture, 1 intracranial hemorrhage, and 10 lacerations that required a suture. Many patients underwent additional investigations, such as a CT scan or an X-ray to check for injury. And there was some evidence that the outcomes for patients appeared to be specifically related to rehabilitation. And these included things like removing equipment to limit unsupervised use, change to therapy schedules, and patients being frustrated with bed and chair alarms. The focus groups identified that falls have a range of impacts to patients. They discussed that despite falls with harm, such as fractures being uncommon, the impact of a fall on a patient is still significant. One participant described it as a total breakdown at times. They viewed that these impacts could affect patients in terms of confidence, pain, and mental health. They also viewed that falls have a negative impact on the rehabilitation journey. In terms of the organisation or the health service outcomes, there were the obvious financial costs involved in the additional investigations that patients required and in hiring personal and preventative equipment such as floor-line beds and bed chair alarms. There were also impacts to hospital resources. For example, patients often required multiple staff members to attend to them after a fall. There was the staff time in documenting and investigating the incident report and the extra checks or roundings that staff provided each shift to help prevent a fall. Following a fall, the majority of patients were reviewed by a doctor. The medical records reflected that examining patients with communication disability was difficult. Often the team used physical examinations to determine which part of the body made contact with the floor and if the patient hit their head. Team members found it difficult or impossible to determine changes to the patient's neurological status. For example, an entry in patient's medical notes reads, "Neuroobs unattainable," as the patient's unable to follow instructions. After a fall, participants in the focus groups, in particular the doctors, reported that it was difficult to assess these patients for injury and described that these difficulties may actually lead to a delay in commencing treatment. One participant explained, if a patient cannot actually tell what he or she is going through, if he or she can't explain the level of the particular ailment to the doctor, how do you expect the doctor to commence treatment? The focus group participants described this process as complicated and frustrating and daunting. However, despite all of these challenges, they also described attempting to help patients with communication disability to describe injuries, and one noted, "We try our possible best so we can help them improve their health." So nearly half of the patients experienced multiple falls, and the documentation revealed that staff had difficulties implementing further falls prevention strategies. So you can see in this really long quote, it shows that falls are an ongoing problem. It lists the strategies that are in place, and it suggests that the patient's communication disability is contributing to the repeated falls because the patient can't call for assistance and is attempting to address her toileting needs. When the circumstances of a fall were unknown, this further complicated the implementation of falls prevention strategies. There are some patients who experienced multiple falls. There appeared to be almost a shift in the focus from falls prevention to minimising harm, such as all strategies are in place to optimise his safety. So I just want to have a quick turn to the staff impacts for a moment. So participants in the focus group viewed a patient's fall as negatively impacting them. They described falls as upsetting and distressing. They viewed that when a patient experiences a fall, they often question their management or treatment plans. For example, you always think, "Oh my gosh, was that because I didn't speak to the physio about a risk minimisation strategy?" Or, "I didn't give enough education." Participants reported impacts to their confidence in their roles as healthcare workers. And this is described by a participant who said, "This is really complicated, kind of like make you feel like you don't really know what to do or you're not good at your job." One participant described falls as a learning experience, and that participants in focus group 1 in particular spoke of the impact of falls on the health service in relation to additional workload. And it's described as there was extra work in assessment, in incident reports, and that it takes time off the floor. So today I presented the integrated results of my PhD as a journey through falls management. The results can be summarised into three key themes: an invisible problem, painting the picture, and a complex problem. An invisible problem highlights that communication disability is invisible and it's not considered in clinical practice, falls research, or falls management. Painting the picture describes the nature of communication disability in falls. Patients often experience unwitnessed falls and usually rolls from bed. They were found on the floor by nursing staff, and falls often occurred when patients were attempting to address a need, taking a risk, or having difficulties following instructions. Nearly a third of the patients who experience a fall are unable to describe what happened, and nearly half of the patients experience more than one fall. The final theme is a complex problem, and this highlights that the multiple impacts of communication disability has on falls management. And I'm going to quickly revise this for you now. So here we have the falls on one side and the specific aspects of communication disability that I have talked about now. So, impaired receptive language and difficulties following instructions are contributing factors to falls. They impact on the circumstances of falls and on post-fall assessment. Difficulties gaining the attention of staff is a contributing factor to a fall. It impacts the circumstances and falls prevention. Difficulties communicating basic needs is also a contributing factor to a fall. It impacts on the circumstances and on falls prevention. And severe communication disability is a contributing factor. It impacts the ability to determine the circumstances of a fall, post-fall assessment, and falls prevention. So you can see how complicated it is. So the way forward. Effective falls prevention programs are implemented because of comprehensive assessment of risk and contributing factors, and then interventions that are designed to specifically address these factors. The first step in the way forward is identification of communication disability as a potential risk and contributing factor for a fall. The focus groups were really clear in their belief that there is a role for speech pathologists in falls management. One participant stated, absolutely there is a place for speech to be involved in falls prevention. Another said that education and work in the fall space would have a big impact on the patients that we provide care for. So whilst there's no screening tool that's designed to identify those specific aspects of communication disability that contribute to and are risk factors for a fall, clinical judgment has been shown to be just as good as using one of these tools. So by assessing the aspects of communication, including their functional impact in the hospital environment, and documenting those in the notes clearly in relation to falls, we may be able to provide more targeted, patient-specific falls prevention plans. And not only that, we may actually be able to help other health professionals start to recognise the role of communication in falls and improve their clinical judgment. So maybe the next time they see a patient who's unable to use the call bell or get attention, they may look at that and go, oh, and think about how that relates to a fall. So in relation to possible falls prevention strategies, across all 6 studies, there were 4 really clear key actions, and they were using family members, documentation of communication disability, adapting falls prevention education programs, and supported communication following a fall. So patients with communication disability following stroke require tailored falls prevention strategies. The focus groups agreed that falls prevention for hospital patients requires multiple specific strategies that include standard falls prevention, but also individualized patient-specific strategies that consider communication. Family members play an important part in falls prevention and can often take on the role in assisting communication. The focus group suggested that family members can provide insights into a patient's personality. For example, if they're the kind of person that can get up and do it themselves or not want to bother the nurses, the things that can provide insight into which strategies might actually be effective. Family members may also be able to support falls prevention strategies such as reminders to use the call bell or prompts to follow safety instructions. Family members were a key part of the falls prevention strategy across all of the hospital falls prevention policies. Information about a patient's communication, its function, and strategy should be clearly documented, and this will support the team to optimise communication. The medical record review found that some health professionals were using adapted communication during high-risk tasks like transfers, but this could be further supported by speech pathologists. For example, developing a set of instructions suitable for patients, for a patient's comprehension skills that staff might use during a transfer. All of the hospital falls policies included recommendations that patients be provided with falls prevention education. And the clinical guidelines for stroke state that all stroke patients should receive education. But the reality is that this education is probably not adapted for patients with communication disability. As speech pathologists, we have the skills to improve the accessibility of falls prevention education to suit the needs of our patients, and this may empower them to be a more active participant in their falls prevention plans. Speech pathologists also have the skills to support a patient to communicate about a fall, to describe what happened, what they were trying to do, and if they have any injuries. And this might help match falls prevention strategies to the contributing factors for falls and provide timely and appropriate treatment for any injuries. So what I've presented today is a synthesis of evidence that relates to falls in hospital patients with communication disability after stroke. I've highlighted that communication disability is invisible. It's not fully considered in falls research or clinical management. I've painted the picture which highlighted the nature of communication disability in falls, and that falls in patients with communication disability is a complex problem and has multiple impacts on falls. These themes led to the way forward, where I presented some guidance for health professionals to manage the falls in patients with communication disability. So the purpose of this was to build an evidence base to improve the care for patients with communication disability following stroke who experience a fall in hospital. The studies were conducted in an Australian context, and whilst these implications may not be applicable to other settings, the broad issue for communication disability as an under-recognised risk factor for a fall is likely to be relevant across all health settings. So there's much research to attend to in relation to falls in these hospital patients. Observations and interviews with lived experience. Patients could provide further insights and evidence about how to help manage falls. And there's also needs to be research to examine the effectiveness of falls prevention strategies, particularly for patients with profound communication disability, where some of these strategies that we can put in place may not actually be effective. So this is the final slide, and it summarises the evidence I've presented today to take back to your teams. You can use it to start a conversation, as a ward poster, or as a prompt for clinicians, and it covers the 3 key areas of falls management. So I'm very happy to share this with you and happy to chat anytime, in person, email, LinkedIn, whatever. Thanks.
Thanks so much, Beck. Very interesting, and it's I think I might have heard through Twitter about you starting this topic in your PhD and was like, oh, that's interesting. So I guess you've kind of ventured into an area that perhaps speech pathology isn't normally that involved in. So thank you for presenting that work. We'll get to some questions in the Q&A in a moment, but I'll just start with a broad one. I mean, falls is a huge priority. It's a huge cost, and I think it's sort of one of the national quality standards, right? So with all these resources being thrown at it, how is it that communication has been fairly invisible? Like, how has that happened, in your opinion?
So, yeah, it's really interesting because I think when we look at the literature prior to me doing this work, there were some really clear difficulties with including people with communication disability, and I think that's really common. There was a recent systematic review that talked about the inclusion of people with aphasia in stroke research, and that has also extended into the falls space. Often people find that people with communication disability are very hard to consent, and it's almost like we've kind of put them in this really too hard basket. So let's just pretend they're not there. So in the literature, the majority of the studies excluded patients with severe communication disability. The inclusion rate was as low as 3%, when we know that it's well over 2/3 of people that have communication disability after a stroke. The studies were using, the initial screen that you get when you're in ED to diagnose a communication disability and not a speech pathologist.
Right.
And then there were really variable definitions. So, for example, one study included patients with dysarthria and patients with slurred speech, which are actually the same kind of thing. Yeah. Yeah.
So how is it then, just to sort of counter that, like cognition is sort of more examined, right? And yet you might say there's the similar kind of challenges and consent and so forth.
Yeah. And I think it's because cognition has been recognized as actually an independent risk factor. So when people
Right.
come into hospital, they're confused, or have a dementia, it's automatically recognized that their behaviors associated with cognition are what gives them that extra risk, as compared to a communication thing where we're talking about functional impacts.
Yeah.
That
There's a
makes
more
sense.
concrete link, perhaps,
Yeah.
or
Yeah.
more obvious link, might
Yeah.
be a better way to put it. Okay, question from Chelsea Larkman. Was there any information in the medical record audit about whether any of the stroke patients were from a CALD background and didn't speak English, or whether that further increased the risk or incidence of falls?
Yeah, so it's not something that we looked at specifically, but there is a colleague over in the States, Professor Natalie Douglas, who's actually recently published a study last year that talked about exactly that. And people who don't speak the same language as their healthcare provider are at a higher risk of a fall.
Mm-hmm. So in your work, the communication disability, was that defined as an acquired disability or just a difference or
Acquired disability as a
yeah,
result of the stroke.
yeah, right.
Yeah, we made it very narrow.
Well, no, it's specific. Thank you. Kathleen Mallon says, fantastic presentation and incredibly important work. Given your patient level data was from the inpatient rehabilitation setting, I'm wondering if any similar work has been completed in the acute setting or if you have plans to do so.
I haven't looked at the acute setting. I know that there are some works in place looking in the community. And I have partnered with some people in America to look a little bit more broadly across different settings. But a lot of the existing falls literature is in acute. So, yeah. Yeah.
Okay. Annie Hill said, thanks so much, Beck, for this very clear and powerful presentation. The statistics are quite shocking.
Mm.
Do you think there is a role for technology in developing solutions to prevent and manage falls?
Absolutely. I think there is a way forward for technology. I think, but that also comes with other inherent issues. So, say if we were to use a camera and we put a camera in every patient's room, who is sitting there and watching those cameras? You know, so it doesn't actually, yes, there is a role for technology. I'm just not quite sure what that is and what that looks like.
Yep.
Yeah,
Speaks back to that complexity of
it is.
the
Yeah. And
challenge.
a lot of the focus group participants, when they were specifically talking about bed chair alarms, like a form of technology, where a person gets up and the alarm goes off. So they talked about, as patients moved through their rehabilitation journey, they learned how to turn it off, or they learned how to wriggle a little bit further forward when they got to get attention. Or that it went off so often it just became like white noise.
Yep.
Yeah.
I remember hearing, because I used to hear them on the wards, and I remember hearing that they weren't particularly effective from
Yeah.
someone, and I couldn't understand why, but that does make sense.
Yeah, so there's actually no evidence in falls for bed chair alarms being effective. And there are some projects going on now about disinvesting in using bed chair alarms.
Yep. All right. Robin Gibson says this is fantastic. These are staggering numbers in terms of the relationship between falls and people with communication disability She says she's been working with the Falls Prevention Service for the first time, was included in a recent Falls Prevention Study Day. She's basically wondering if she can share this work because she's not sure if that's allowed or not.
Absolutely. So it'll be on YouTube.
Yep.
Yeah, so you can share that. But Robin, I'm very happy for you to send me an email, and would love to chat further. Yeah,
Yep. She also added that she's hoping it's the beginning of a whole new aspect of working with, multidisciplinary teams.
I hope so.
Dominic Cadillac said, great presentation. Could you highlight the role of speech pathologists in providing communication tools to patient to support patient needs like toileting?
Yeah, I think this is a really interesting concept for inpatient rehab speeches. And I know that the length of stay is getting shorter, and the focus tends to shift a little bit more towards how we're going to get people out of home, back, into home, or
Mm,
where are we going to? But communication disability in a hospital setting actually has a wide range of safety implications. So it's not necessarily about falls, it's also about, how do these people do a 3-point ID check? What are their risks of a medication error? What are their risks of a pressure sore if they can't get attention and they need personal hygiene and they're sitting, for quite a while in a situation where they need their toileting needs attended to.
mm,
Um, so the role of speech pathologists, I feel, also needs to address some of these functional things in a hospital setting so that we can empower these patients to be a part of their healthcare rather than just doing healthcare to them.
hmm
Makes sense. Telling them when
Yep.
they're going to go to the toilet, telling them when they need a shower, telling them when they're going to eat their meal. They have no agency and no control in those situations. And as speech pathologists, we actually can implement rehabilitation that's functionally based to change some of this. A different call bell strategy, some sort of alternative communication strategy to facilitate transfers, or alert the staff to needing the toilet. There's a really big role here for us.
Mm. Now that's not routinely done as far as I'm aware. Is that because speech pathologists aren't thinking in that way, or is it because there's not sort of space for them in the system to be part of that, or both?
I think it's possibly both. I think the
Yeah.
system is under so much pressure for people to find a discharge destination,
Mm,
to make that discharge destination safe. I think that the complexity of people and patients that do go to inpatient rehabilitation now is so much greater, and
mm,
people are coming to inpatient rehabilitation with greater functional impairments across the board, which is adding to their complexity. Mm.
yep. Yep. We have a question from Christian Pitzner. Thanks for your presentation. Are there any key blanket interventions that you may recommend for at-risk patients with stroke?
Yeah, I think that's a really interesting question because falls prevention strategies work when they're patient specific.
Hmm.
Yeah, so there are those really, the standard ones about doing risk assessment and making sure they have the things that they need. But essentially, falls prevention strategies are effective when they're patient specific.
Yep. Yeah, so it's hard to have a blanket.
Yeah.
Yep. Sarah Calvi just wanted to know if you could share any details of the research regarding disinvesting in bed and chair alarms. Do you want to
Yeah,
put
so
forth
that's
a
been
name or?
done. I think that's recently published by Kelly Stevens. She is an OT doing her PhD here at, I want to say Monash. Yeah.
Yep.
Kelly Stevens and Terry Haynes are doing those projects.
Good reference memory.
Yeah.
I might just finish with a couple of questions. Oh no, one has just come through. I better do that one. Edwina Lambin, more of a comment that may trigger some thought. Thanks for summarizing your work, which I have cited many times in my own I wonder if there is a place for a speech pathologist whose role is specifically for interdisciplinary work to support communication between patients and their care providers, rather than providing therapy and working towards the
Mm,
patient's goals.
yeah, it's an interesting point. I think the role of speech pathologists can be so diverse, and often speech pathologists feel the burden of all of the patients with communication disability, and the staff rely really heavily on us, and that's a weight, you know.
Hmm.
Um, they rely on us to do all of the supported and accommodated communication strategies, and rely on us to communicate with the family, and it's a big burden. Yeah.
Mm, yep.
Yeah.
Um, I know that you've looked at risk factors more than different interventions, but and everything is complicated and each person needs something different. But if I give you a magic wand to implement something across every hospital, every stroke rehab ward, do you have an idea of what that might be?
I think probably the first step would be around linking the factors that contribute to a fall. So, the communicating your basic needs, using a call bell and following instructions, linking that specifically to the risk. That would be my
Hmm.
very first step.
As opposed to blanket strategies, is that what you mean?
Yeah. So
Yeah.
saying, hey, look, this person has this, this, and this, and therefore those things might actually contribute to this person having a fall. And
Yep.
it's starting with awareness.
Yep. I was also interested, you mentioned that family are a huge sort of protective factor. Do you know if that, during COVID, when a lot of family was not allowed in, and there were all sorts of levels of restrictions on visitors and so forth, did that impact falls at all? Are you aware of?
There was a study or a comment, no, a comment in the focus group that did talk about the impact of COVID and how they felt that there was an increase in falls. And there
Mm,
was a study not necessarily conducted in inpatient rehab stroke that did find the fall rate did increase without family members being there.
yeah.
Yeah.
Yep. I guess that having visitors kind of fills the gap sometimes.
Yeah. Yeah, and
So
hospitals
that
rely greatly on visitors to
yeah,
fill those gaps in staffing. You know, when you can't afford to have a one-to-one nurse, or, you know,
yeah. I know in some countries that food is not provided, and it's the family's job to be there and bring food, and so we're not at that level, but clearly there is a reliance and an
there is a big
expectation.
reliance on family. In the, just as an aside, in the falls policies, it talked about all of them. If you can't provide falls education to the patient, you give falls education to the family.
Hmm. So if there isn't family around, if they're not someone who has support, that's
Yep,
okay.
you miss out on falls education. Mm.
Yeah. All right. Last question for you is I know you've got a lot of different sort of streams of research, but do you have anything coming up next, or what do you think is next for whoever's looking at this?
Yeah, so I think what's next is potentially to trial um, what it might look like if we use some adapted communication strategies in some of these aspects of falls. I think the thing that struck me the most was the impact of severe communication disability,
Mm,
and the fact that these are the people that are having multiple falls, and we still aren't sure why. And perhaps if we could adapt communication and have some conversations with these people, we might understand what it is that they're trying to do. And understanding those circumstances is one of the keys to unlocking a falls prevention strategy.
hmm.
Yeah.
Yep.
The other thing I think is important, and this is something I'm currently working on, is really identifying communication as a risk factor as opposed to just a contributing factor. So we can identify at the very beginning of a patient's journey, hey, this communication is just as important as a balance impairment.
Yep. Well, thank you again. It's
Yeah,
we know how aphasia research benefits from other disciplines, and I think this is an example of the reverse, where the speech pathology perspective has contributed to other interdisciplinary research. So Thank you for presenting that.
Thank you.
If you would like to catch any details from today's seminar again or share it with others, then this recording will be uploaded to the Aphasia CRE YouTube channel fairly soon, where you'll also find all of our, or most of our other previous sessions. To stay connected with our other work, you can follow the CRE on our blog or Facebook or LinkedIn, and they're a great way to keep up with what we're doing. Our next seminar is coming up fairly soon, a little earlier than our usual gap, just a few weeks away on September 24th at 4 p.m. Melbourne time. And we're going to be joined by Dr. Samantha Siambalapidia from Griffith University, who's sharing her research on how speech pathologists deliver services to bi and multilingual adults with aphasia in hospital settings. Hope to see you then. Thank you, everyone.